Hi folks, welcome to my YouTube channel. So today we will go over the usual interstitial pneumonia UIP, which is also known as the idiopathic interstitial fibrosis, idiopathic pulmonary fibrosis, or cryptogenic fibrosing alveolitis. So before we discuss further about the UIP, let's revisit the different type of the patterns which we can see in the chronic interstitial pneumonias. So whenever we have a lung tissue under the microscope, and first thing we have to interpret whether the lesion is present in a diffuse manner versus the patchy manner. Then if the lesion is present in a patchy manner, then mainly we have a three differentials. One is the UIP, which we will discuss today. The second is the COP, and the third is the RBILD, which we have already covered. So if we have a patchy type of the lesion, then the second thing we have to look for is the whether the lesion is present in a homogeneous manner versus the heterogeneous manner. So the homogeneous manner means that lesion is taking place all at the same time, and heterogeneous means the lesions is present at the different levels. Some is advanced, some is still originating. And if we have a heterogeneous type of the pattern, then the most likely diagnosis is the UIP. But we have to still see some specific features microscopically in order to diagnose the UIP. And UIP is a combination diagnosis of a clinical, radiological, and the pathological findings. It's not a diagnosis of a one subspecialty. So discussing about the definition, so uh, it is one of the chronic lung injury which is characterized by the diffuse interstitial fibrosis with temporal and the spatial heterogeneity. And as we discussed, it's a correlated diagnosis of a clinical, radiological, and the pathological findings. So discussing about the epidemiology of this entity, it is commonly seen in the older age where with the male predominance, and the cases are 10 cases per 100,000 per annum, and mostly the patients have the history of a smoking or any other connective tissue type of the diseases. While the clinical presentation could be totally non-specific, and it can mimic with the variety of the other lung injuries, and the clinical manifestations are commonly are chronic dyspnea, dry cough, fatigue, digital clubbing because of the prolonged hypoxia, and on the chest auscultation, there could be fine crackles which are mainly present on the basal aspects of the both lungs. Somehow this disease has a predilection to prominently involve the basal aspects of the lungs. So discussing about the pathophysiology of this entity, so the first and the key event is there is a damage to the alveolar epithelium or the pneumocytes. The other theories for the pathophysiology includes there could be the aberrant WNT or beta-catenin signaling pathway, which will lead to the abnormal accumulation of fibrosis and the collagen and the smooth muscle hyperplasia, which will lead to the abnormal remodeling and distort the normal architecture. And another is the increased TGF beta 1 activity, which will lay down the abnormal collagen and then cause the fibrosis in that entity. While discussing about the radiology, so HRCT has the most is the one of the most significant tool to diagnose the uh, different type of the patrons in the chronic interstitial pneumonias, and HRT is also one of the best tool for the see the different type of the patrons in the UIP. So the most common pattern which seen on the HRCT is the reticular type of the patron, and along with that there will be the dilatations of the small bronchioles as well, mainly present on the basal aspects of the lungs. The other features includes intralobular linear opacities with irregular thickening. Other includes irregular pleura, vascular, and the bronchial interfaces with the lung parenchyma. And the most significant changes which will give a clue that the disease has been advanced is the honeycomb changes. So the honeycomb changes are commonly seen in the advanced stages, and they represent the advanced dilatation of the bronchioles, and we will go over the honeycomb changes when we will discuss about the microscopic features. So this is one of the radiology for the UIP. So here on these basal aspects, we can clearly see a prominent reticular type of the pattern, and the second feature is the dilatation of these small bronchioles, and we can also see there is an interlobular thickenings as well. And as, as as we said earlier, the most prominent and the significant is that they commonly involves the basal aspects of the lungs. So discussing about the microscopic features of the UIP, there are multiple, but out of them there are four significant factors which will make a determination of the UIP. So the first thing we have to look for under the low power of the microscope is that whether the lesion is present in a diffuse manner versus present in the patchy manner. So here is one of the lung tissue. Here we can clearly, if we orient first or orient ourselves, here is the pleura, and we can clearly see there is some pleural lesion, and in the if we come on the center, we can see some normal architecture of the lungs. So first thing we can make clear distinction is that the lesion is present in a subpleural manner and present in a patchy manner, which is one of the significant feature. The second feature is that again, if we go and first orient ourselves, there's a pleura, and there is a diffuse subpleural fibrosis, and near to this area we have some normal architecture as well. And the second significant feature is that these dilatation of these bronchial epithelial lining cyst, and as they go more advanced, there will be more accumulation of the fibrosis and the collagen in these alveolar septa, and sometimes they have some mucus and the debris inside these cystic spaces. Then these changes are known as the honeycomb changes. And the third significant feature is these fibroblastic foci, which are composed of the myofibroblast, and they are present in the myxoid or the pale gray type of the stroma. And the location of these fibroblastic foci is very significant. The first is that they are located outside the alveoli, and they are present around their walls. But we have to make a differential diagnosis of these fibroblastic foci versus the Mason bodies. So the Mason bodies have the almost the similar type of the composition, but they are present inside the alveoli, and they are commonly seen in the organizing pneumonia, while the fibroblastic foci are located around the walls of the alveolar septa, and they are commonly seen in the UIP. So, and another thing is that these fibroblastic foci are mainly located at the interface of the fibrosis and the normal lung architecture. So these are the 3 or 4 significant features to make a diagnosis of the UIP. While in terms of a prognosis and the treatment, it is one of the disease which has the poor prognosis, and the mean survival range is from 3.5 to 5 years, and it is one of the most respiratory cause of respiratory failures, and can lead to the death as well. So the treatment approach in these type of the lesion is that if it is a most advanced, then lung transplantation is the only option. But if the lesion is still in the initial phase, then tyrosine kinase inhibitors can also be included. So this is the end of my presentation. Thank you so much.